Welcome, everyone. It is a pleasure to have you here today for the Adolescent Idiopathic Scoliosis Patient Education webinar presented by the Scoliosis Research Society and the Society on Scoliosis Orthopedic and Rehabilitation Treatment. This collaborative effort is a pleasure to be a part of. The Scoliosis Research Society is considered to be one of the premier organizations in the world. For over 50 years, it has provided care to all patients and is a leader in the scientific research and education in this field. It includes over 1,000 leading spine surgeons, researchers, physician assistants, and orthotists who are involved in this research and treatment of spinal deformities. SOSORT is an international organization focused on fostering the best conservative management for scoliosis and other spinal deformities, and to encourage multidisciplinary teamwork, including scientists, medical and healthcare professionals, patients, and their families. Together, these two organizations provide optimal care for the scoliosis patient community. As you perhaps have seen, I'd like to go over the topics for today and introduce our presenters. The first presentation will be on your spine and scoliosis, giving you a basic understanding of the spine and what happens when there is an abnormal curvature that may occur. The second presentation, this will be the first one, by the way, will be given by Sabrina Donzelli. Dr. Donzelli is a medical doctor working as a clinician and researcher at the Italian Scientific Spine Institute. She is the author of various publications in the field of spine pathology, and she is a course coordinator for the Principles and Practice in Scoliosis Conservative Treatment. She has won many awards in her field, and she is the associate editor for the BMC Journal. Our second presentation will be What Can I Expect? What happens if in fact you do have scoliosis? What does it mean? This will be presented by Dr. Theo Grivas. Dr. Theo Grivas is a medical doctor and a PhD in orthopedic and spinal surgery who graduated from the medical school at Aristotle University of Thessalonica in Central Macedonia, Greece. He is currently the director of the Traumatology and Orthopedic Department at Zanio General Hospital of Piraeus in Greece and the president of the Hellenic Spine Society. He is the chief editor of the Scoliosis and Spinal Disorders Journal and the associate editor of the Spine Deformity Journal, and he is a member of the editorial board or reader for many books and articles in peer-reviewed journals. Our third presentation will be What Can or Should I Do for My Child? And this will be presented by Dr. Stefano Negrini. Dr. Negrini is a professor and medical doctor and professor in physical and rehabilitation medicine at the University of Brescia in Italy. He is the scientific director of Vado Research Hospital for the Foundation Don Noci in Milan and scientific director of ISICO in Milan. He has published more than 250 papers in the peer-reviewed journals and 30 books in Italy, and has been the keynote lecturer at many meetings throughout the world. Our fourth and last presentation will be on what if the curve progression continues. Dr. Tomas Kodvicki will take a look at the various options that we have in today's world for perhaps a surgical option if you have a continued curve progression. Dr. Kodvicki is also a doctor and a PhD. He's an orthopedic spine surgeon, professor of orthopedics, the head of spine disorders and pediatric orthopedics at the University of Medical Sciences in Poznan, Poland. He is a member and officer of many spine scientific societies, and he is the deputy editor of Scoliosis and Spine Disorders, and he has published 90 papers in the peer-reviewed journals. If I could go back to that previous slide, please. Jenny, previous one. Thank you. I would also say that today, two co-moderators for today, for this session for you, will be Dr. Masood Shafafi from the UK, Nottingham University Hospital, and myself, I'm Joe O'Brien from the National Scoliosis Foundation. And I would like to say that on behalf of all the patient community, we are incredibly grateful for these presenters today and for these two societies who are providing optimal care to this community. Here are the disclosures for the presenters. And now I'd like to turn it over to Dr. Donzelli.
So, hello everyone. Thank you, Joe, for the presentation. So, I am here to introduce the anatomy of the spine and what it means to have abnormal curvatures. First of all, perfect. The spine is a quite complex part of the body. We talk about the vertebral column, and it has the function to protect the spinal cord and to support the head and neck. It's done by 26 bone, 24 are vertebrae, and then we have the sacrum and the coccyx. Next. In the frontal plane, in healthy subjects, the column is straight, while in the lateral projection, we have different curvatures. The cervical curvatures, which is called cervical lordosis. Then we have the thoracic kyphosis and the lumbar lordosis, and finally the sacral curve. Next. Then each part is made by a different number of vertebrae, and each vertebra in the different part of the column has a different morphology. So we have the neck, which is done by 7 cervical vertebrae. Then the upper back, which is the thoracic part, made by 12 thoracic vertebrae. Each one articulates with the ribs and then with the rib cage. And then we have the lower back, made by 5 lumbar vertebrae. Then we have the column, which is articulated with the pelvis through the sacrum and the coccyx. So, next one. And so this is the basic of the anatomy, but next, please. Perfect. But during growth, we have during life some period with rapid growth. The most important period of life is the pubertal growth, in which very rapid body changes happen. And so these are crucial moments for growth. Next one, please. Growth is normally asymmetric, and sometimes it generates discord. I think that it's normal to see that our sons and daughters change their body shapes, and in some cases they change also movement during this rapid period of growth. This is quite typical in adolescents, but it can happen also in younger child, for example, between 6 and 8 years of age, because it's another period in which the growth is a little bit more quick than in other period of life. So this makes some changes. Next one. So it happens that we can see some asymmetric in the body of our children, young boy and girls, and in some cases it's normal to see a leg length discrepancy, which is a typical sign of growth, but it happens to think that leg length discrepancy is a sort of omen of scoliosis. In reality, it's normal that leg grow in a symmetrical way, and so in rapid period of growth, it's normal to have a leg length discrepancy. Next one. And also, asymmetries in the trunk sometimes are related only to growth, while in other cases are related to spine deformities which is coming out and progressing. So how to distinguish these kind of things? First of all, we have to look at the body of children and boys when they are growing, but not worry too much about asymmetries. Why? Next one. Because the anatomy of scoliosis includes the three-dimensionality of the deformity. Scoliosis is a three-dimensional deformity. Next one. Which change something in the frontal plane of the spine. So we can see a curvature in the frontal plane, which generate asymmetries of the shoulders, of the scapulae, and of the waist. Next one. But also we have deformities in the lateral view of the spine. We have, as I told you before, we have lumbar lordosis, a thoracic kyphosis. When there is a deformity of the spine, the curvature, the typical curvature in the lateral view of the spine changes. So we may have a loss of thoracic kyphosis, for example, or an increasing in the thoracic kyphosis or a kyphosis in the thoracolumbar part of the spine. Next one. And then the third dimension of scoliosis is the transverse plane, which is characterized by a vertebral rotation. Next one. So when there is a vertebral rotation, what happens is that there are some deformities in the trunk. For example, when we have a rotation in the thoracic vertebra, then we have some ribs deformities. Next one. And so the most important instrument we have to understand if we are evaluating an asymmetry only related to growth or a true deformity of the spine is the measurement of the rib hump by asking to the subjects we are evaluating to bend forward. We can measure with this prominence with an instrument, which is the scoliometer, and it's possible to measure it, and then the expert in the field is able to suggest what to do next and to decide if the prominence measured is a true omen of scoliosis or not, because in some cases when we have a leg length discrepancy, it's only related to that and not to a true deformity. So the expert is able to distinguish these two possibilities and then advise the patient on what to do next. Next one. And generally, what to do next is if it's necessary or not to perform an X-ray, and this is a decision made by an expert specialist in the field. X-ray can be useful to evaluate the deformity, but also to monitor scoliosis during time and to monitor the effect of treatment. Next one. So if you have some doubts and if you are at home and you want to understand if your son or daughters have a hump, and so you have the suspect that they have some spinal deformity, you can use this very simple instrument. You can construct it. It's homemade, and you can find to this link the instruction to create this torsion bottle, able to make you aware if your sons or daughter have a significant rib hump, which should be evaluated by a specialist. And I thank you for the attention.
Hello from Athens. I'm Theodore Grivas, and I'm going to speak on the natural history of idiopathic scoliosis, from now on abbreviated IS. In other words, what the person suffering IS can expect, and on the role of growth and the problem of progression. Next, please. Next, please. Let's start with some definitions. Scoliosis, as it was said, it is a 3D deformity, affects all ages, both genders, and can be found around the world. Next, please. Next, please. What idiopathic IS means? Idiopathic means we don't know the cause. IS is the most common type of scoliosis, 85% of cases. Next. There are various types of IS. If it is developed in infancy or childhood, it is named infantile and childhood IS respectively. These two types are included in what it is said early onset scoliosis, or EOS. Next, please. Next, please. Adolescent Idiopathic Scoliosis, or AIS, is named the scoliosis which develops in preteens and teenagers before bones become mature. This type is much more common in girls than boys. Next, please. Next, please. On an X-ray, the spine looks more like an S or C rather than a straight line. Next, please. Now, let's see what are the signs of AIS. If we observe a girl with scoliosis, we may notice that one shoulder may be higher than the other, one shoulder blade may be more noticeable, with the arms at the side, there may be more space between the arm and the body of the side, one hip may be higher than the other, the head may be not centered over the pelvis, the breasts may be asymmetrical, and on bending forward, one side of the back may be higher than the other. Next, please. Next, please. There are numerous classifications and sub-classification systems for IS. However, what it is more noticeable is the appearance of the child, and here is showed the classification of scoliosis on the basis of the location of the spinal curve. Radiographs, top panel, corresponding patient photographs, bottom panel, show the more common 4 types of scoliosis classified on the basis of the location and the apex of the major spinal curve. 1 is the right thoracic, 2 is the thoracolumbar, 3 is the lumbar, and 4 is the double primary, which results in a more balanced body image. Next, please. The causes, in other words, the etiology of scoliosis. So far, there is no current known cause of IS. What we know is that frequently runs in families and may have genetic component, yet there is ongoing active research to identify these genes. However, there are other types of scoliosis of known cause, namely the congenital scoliosis due to defects of vertebra and the neuromuscular scoliosis due to neurologic or muscular conditions. Next, please. Next, please. Let's see now what we know for the natural history, that is, what it may happen in the future in people suffering idiopathic scoliosis. There is some scientific evidence. Next, please. 90% of cases are mild and do not require active treatment. However, these cases must see a scoliosis specialist to ensure appropriate care. It is very important for growing adolescents to follow up with the treating surgeon if scoliosis is diagnosed. It is important to know that repeated physical exam and X-rays may be needed. If there is an increase in scoliotic curve, then the child may require bracing and occasionally surgery. Next, please. There are some reports for the fate of the untreated adolescent idiopathic scoliosis. In 1968, Scandinavian studies reported on long-term outcomes of untreated scoliosis. There are several limitations about this study. Overall poor quality. It was reported increased death, chronic low back pain, yet heart and lung problems. This misinformation created high anxiety among patients and families. Next slide, please. University of Iowa in the 90s reported a long-term study of patients with IS. It was reported a 50+ year follow-up of untreated scoliosis patients who were followed from their teenage years throughout their life, and their average age was 66 years at follow-up. Next slide, please. It was shown that AIS patients with no severe thoracic curves generally do not face an increased mortality risk compared with people without scoliosis. Usually, there are no severe lung problems when scoliosis begins in teenage years, but lung failure and early death may occur in early onset scoliosis. If the curve is more than 50 degrees, clinically there is decreased pulmonary function, and if curve is more than 80 degrees in the thoracic spine, there is much higher shortness of breath. Next, please. Also, from the long-term follow-up data in untreated AIS, it was shown that curves less than 30 degrees at skeletal maturity in general did not progress much. Curves 50 to 75 degrees in the thoracic spine progressed the most, and double curves, thoracic and lumbar, are balanced with age and maintain alignment. Next, please. As far as the back pain in untreated AIS, it was shown that there may be more chronic back pain, more severe acute back pain lasting longer, but for these patients, scoliosis did not affect job or household activities, and there is no higher level of functional disability. However, they reported higher level of cosmetic concern. Also, 32% reported some life limitations for purchasing clothes, self-consciousness, and also they have decreased physical activity. Next slide, please. As far as the quality of life, in the untreated AIS, it was shown that these persons function well as adults, are employed, and as far as the marriage and childbearing concerns, in the largely untreated IOVA series, the IS did not appear to be detrimental to becoming married or childbearing. The curve progression in untreated patients does not appear to be influenced by pregnancy, and in general, these people are active as older adults. Professor Mark Asser, one of the prominent United States orthopedic surgeons, reported that such knowledge of AIS natural history as is available, although admittedly incomplete, is detailed enough to provide reassurance about the long-term effect of untreated AIS for most patients. Now, next please. Next please. Determining which patients should be treated requires a comprehensive assessment of a patient's remaining growth potential. The commonly used methods to assess patients' remaining growth potential are radiographical methods of bone age assessment. Additionally, some useful information on remaining growth potential is based on the assessing some anthropometric parameters like the change in body height and arm span, and on onset of menarche, the period. And last slide, please. The comprehensive assessment of a patient's remaining growth potential will not only help the doctor to determine which patients should be treated, but in addition, with the knowledge of some other parameters, the treating doctor will be able to assess the likelihood of progression of the curve. Likelihood, which also helps the doctor to tailor the appropriate treatment. The factors related to the progression of the curve are age in years, bone age, bone may mature differently from a child's actual age, degree of curvature, location of the curve in the spine, status of the puberty period. In a premenarchal girl, the curve may be more progressive. And finally, gender. Adolescent idiopathic scoliosis is more frequently affecting the girls. Counseling the patient and family regarding treatment, these natural history data are important and must be communicated with them. And now I pass the microphone to Professor Negrini to speak on the non-operative treatment for AIS. Thank you very much for your attention.
Thank you, Dr. Grivas and Dr. Donzelli, for telling us in your presentations what happens with abnormal curvatures and what could we expect. Now, before we turn to Dr. Negrini, I want to invite all of you and remind you that on your side panel, you should see an opportunity to ask questions. Please write your questions down, and Dr. Shafafi will go through them, and we'll have each presenter answer them, and as many as we can, depending on the priority, and trying to classify them into those that are most important for the majority of the large audience that we have here in the presentation. So please go to the side and write out your questions, and we will make sure that we try to answer them at the end of the presentations. Now, Dr. Negrini.
Thank you very much, Joe. And my topic is quite complicated, and I will try to make it as simple as possible to make people understand what they can expect and what they could try to do for their child. Next, please. As wonderfully has been presented by Dr. Grivas, it's not important to have a curvature in the spine. We can easily live with some asymmetries, and the spine can be a little bit asymmetrical without creating really big problems. But what are the problems that can be created by an important curve, an important asymmetry? There are fundamentally four. One is a problem of aesthetics, and the problem of aesthetics happens to your child, and you can immediately see in your child if there is an aesthetical problem. The second one is low back pain, and low back pain usually doesn't hit in the kid, usually happens in adulthood. And the third point is the progressive deformity, and this is in the kid, but what is most important is a situation at the end of growth that can cause progressive deformity all over your life. And this in the end would create and would impair your quality of life. What is a scoliosis? An untreated scoliosis that progresses during adulthood. We have some examples in the literature, in the cartoons. For example, the Nostradamus, the Hunchback of Notre Dame, is an example of an important thoracic scoliosis that causes a progressive flexion forward. And this, in the end, can impair a lot your quality of life. So we treat scoliosis in kids to avoid these health consequences in adulthood. Next. What research has, please go back one slide. What research has shown us is that there are some critical thresholds. We know that until a threshold is around 30 degrees, we don't run so big risks for adulthood. So in the end, when we treat a scoliosis, we can allow to have a little bit of scoliosis if it does not become too important. And we also know that above 50 degrees, these problems are almost always present, while in the gray area between 30 and 50 degrees, the risk of problems in adulthood grows rapidly. And so this also allows us to understand what to do and how to do it. We should try to avoid as much as possible to reach the threshold of 30 degrees. And when we are above this threshold, we should try to reduce as much as possible the deformity. And when we are above 50 degrees, we should try at least, if it's possible, to avoid surgery, or if it is not possible, we will go to the surgeon. So the aims comes from the quantity of the deformity that we have in adulthood. Then obviously the things are much more complicated. This is just an example to make you understand that it's not important to have a scoliosis. It is important if this scoliosis can really impair your quality of life in the future. Next. Consequently, also the therapeutic tools that we have can be used according to the importance of the curve. In fact, which tools we have? First of all, observation. Observation is really a treatment. If you have a scoliosis, scoliosis doesn't disappear. It can happen only very rarely in very young kids. In all the other cases, it doesn't disappear spontaneously. So if there is a scoliosis, you have to observe it and follow up it regularly during growth to see if it progresses. If the first stage of treatment could be physiotherapeutic scoliosis-specific exercises. We now have proofs of effectiveness of these kind of exercises of different schools from the Schrott treatment to the CS approach to the Lyon approach. There are different schools around the world, and some of these have shown their effectiveness. And then we can have bracing, and bracing can be applied with different kind of materials. We can have elastic bracing, we can have rigid bracing, and very rigid bracing. And also the number of hours can be different according to the importance of the problem of your patient. And as you can see in the figure, it has been proposed a step-by-step treatment. What does it mean? When the scoliosis is very low, observation is enough. If scoliosis progresses and is more important, you can approach it with exercises, but exercises are less effective than braces, and braces obviously are have less favorable outcomes than art plastic braces, casting, or even surgery. So according to the importance of the curve, you will have a different treatment approach. What are the problems that in which you can occur with this approach? If you choose a too high step and the scoliosis of your kid could be treated with a lower step, you are over-treating. And you are impairing the life of your patient, of your kid more than with a lower level step. Or if you use a low step and you are under-treating, you run the risk of much more higher risk of progression, and if the curve progresses, then it's very difficult to go back. So the real problem for the treating physician is to choose the right step for the right patient at the right moment. And under-treatment and over-treatment are both a real issue and problem. What is important is also to choose correctly the treating physician, and it must be an expert. Next slide, please. It must be an expert because you have to understand where you are, and then you have to also, most of all, to make a prognosis. There are periods in time in which scoliosis progresses very rapidly, and in this period of times, you need to know very well the natural history of scoliosis. You need to be able to understand what is the risk that this curve progresses, and then to apply the right treatment. And this is really a question of experience. It's a question of treating many scoliosis, and this is why you need an expert in scoliosis. As you can see in this slide, you can apply the different treatments in different situations, and each situation is applied, require more or less effort of the patients. Next slide. What is also known quite well internationally is that it is not important the type of brace. You will find many different types of brace. We know that some braces are much more difficult to be used. And for example, nowadays, braces that arrive to the neck have been almost abandoned. They are used in very rare cases because of the impact that they have psychologically. But what is important is the expertise in bracing on the part of the doctor and the orthotist. It is also known that it is important to allow the patient to perform the treatment. And a complete, committed treating team is a key to success. So you need a very expert doctor, a very expert orthotist, and you need a good physiotherapist that help the patient follow the treatment. The same is true for exercises. It's very important to apply exercises that have shown their effectiveness. There are so many kinds of exercises that are proposed around the world, and most of them are really ineffective on scoliosis. Some of them are even damaging and causing progression of scoliosis. What has shown to be important is to apply the so-called self-correction. Patients must learn how to correct themselves, and then they have to learn how to stabilize this kind of correction. Exercises will never be as effective as a brace. In the brace, you are correcting and kept in the correction for hours every day. With exercise, you just learn how to self-correct yourself. And it's a way to teach your brain how to counteract better the curve. But exercises cannot be as effective as a brace that is worn hours and hours every day. But again, expertise. Expertise is, again, the key to success. So the final message is find a good doctor, find a good team, find a good orthotist, a good physiotherapist according to the need. It's mandatory to have the good proposal by the good and expert doctor to fight correctly your the deformity of your kid. Thank you.
Yes, thank you very much. Welcome everyone. It's good to be with you for this SRS SOSORT webinar. I'm Tomasz Kotwicki. I work in Poland, Poznań. I'm an orthopedic surgeon, pediatric orthopedic surgeon, and spine surgeon. And I would like to speak a few words about what can happen later if this non-surgical treatment is not effective enough to stop the curve progression. Please, next slide. So what are the reasons to make surgery for scoliosis? So it can be done for curve progression, so increase of the cup angle despite the treatment. It can happen. It can be done for curves that are already big at the moment that you visit the doctor. So they are over 50 degrees, 60 degrees, 70 degrees. Unfortunately, every year we receive the patients that were not treated before, that discover the deformity already at a very important angle. Another reason is aesthetics. So if it is important trunk imbalance, so the thorax is shifted to the side, or if it is a rib prominence, it can be also the reason for surgery. As for the pain, it's very rare if it is idiopathic scoliosis in the adolescent period. So, but it also can be the reason for surgery. Next slide, please. What is, on the other hand, the motivation of the patient to undergo surgery? So first is to get immediate and very important curve correction, because I can tell you it really changes the situation. It can largely improve the aesthetics, the trunk balance, the trunk rotation, so all these external aspects that is so important to the patient and to the family. The other point is that it is a definite stabilization of the spine for the lifetime. So if it is well done and with good indications, and then you can count on that you will be really free of all these braces, daily exercises, and you can forget about the cup angles. Next slide, please. What about the decision making? I think it is important to say that it is a scheduled operation, planned. So there is no direct risk, life risk, health risk. I mean that it is the operation that should be well prepared, and you have time to ask, you have time to discuss within the families or with other doctors. You can check, you can go for a second opinion, and you can think it over. But when you make your decision to undergo surgery, then in my opinion the best is to simply trust your doctor and to follow what he is saying. Next slide, please. What about the timing? Already, if the curve increases, for example, over 40 degrees, I think it's already time to alert the patient and the family that we are approaching the surgical values, especially if there is still important growth ahead. That means that it is increased risk of further progression of scoliosis. So it's important already, especially if the child is treated with brace and exercises, to detect the point that you can say, attention, it seems like progressive curves, it seems like a failure of non-surgical treatment, and to speak about it with the family. On the other hand, in my opinion, it's important, what already Professor Negrini mentioned, to avoid also undertreatment and not to follow so many various options of treatment that you can find in the internet that are presented as miraculous and are non-effective in most cases. Next slide, please. What is the technology? So how it's made this operation? So first you have to have the incision and the scar. In fact, we do not do the mini-invasive treatment for scoliosis because we need to make what is called spinal fusion. So this scar can be posterior, vertical, or can be oblique in the lateral at the side if it is anterior approach. This approach, that means that we put the implants on the posterior part of the spine, where you can find the spinous processus, transverse processus, lamina, and the pedicles, or their implants can be put on the anterior parts of the spine, that means on the vertebral bodies, but it's rarely. The spinal fusion is always the element of the surgery. It can be done at once in one surgery, or sometimes where the curve is important and there is still important growth ahead, we have to make 2 or 3 surgeries or maybe some growing implant. So we say that's a delayed spinal fusion. However, this fusion will take place anyway. Then you need to put spinal implants like screws or rods or hooks or others. And if you have the surgery, you always have risks of surgery. And most of people are most frightened by the neurological risk. And of course, we also as surgeons are very concerned about the neurological risk. So we use the neuromonitoring to be sure that this risk is minimal. However, it will not be zero. There is also infections possible, so we use antibiotics. There can be some mechanical problem with implants, like breaking or dislodging, so it's a question of a very good pre-operative planning. Next slide, please. What is the hospital burden about this scoliosis surgery? First, you need a lot of examinations for the heart, kidneys, blood sample examinations, x-rays on standing position, supine, on traction, bending, etc. And also you can make autotransfusion to avoid the blood that is from the donators, so it's a homologic blood, and to have only your own blood transfused. The surgery is about 3 hours, 4 hours, 5 hours, depending on the number of levels, on the complexity of the surgery. And it's usually 1 day in the intensive care unit with a good pain control. And I can say that I think it's not so painful because these systems that are used for correction are very stable, and so there is no additional movements of this vertebrae. It's well stabilized, so the pain is really well controlled. We start early exercises and the patient is sitting or standing at the second or third post-operative day. And the stay at the hospital is about 1 week after surgery. Next slide, please. So what later? I think that going back to school is about 1 month after surgery, depending on the recovery. Swimming, bike, it's allowed about a few weeks after surgery, after the first visit, usually 4 to 6 weeks after surgery. And the sport that can be progressively performed, we start with non-contact sports after 6 months about, and then contact sports after 9 or 1 year. So 1 year is the period that we consider that is necessary to obtain a solid spinal fusion. And then the patient is allowed to practice nearly all kinds of sports. Next slide, please. So this is our aim, that the patient could really forget about scoliosis. Thank you very much.
Thank you to all our presenters. We are really grateful for what you showed us. And now we have the question and answer session for the next 15 minutes. Please, when you're writing your questions, we ask that two things to consider. First of all, it is not appropriate to answer any specific questions, clinical questions or surgical questions for your individual case. There is opportunity to follow up with the presenters here or other people within the societies to try to get that particular information. Secondly, so therefore, keep your questions as short as possible so we can get to as many of them as we can. I'd like to open up. Perhaps there are several questions that are referring to the long-term impact, whether it be on the non-operative side or the surgical side. So I guess we'll start off with Dr. Negrini. And the question really came from several people, and it was, if my daughter does not want to have surgery, so what is the impact if she was just to continue, and she's at a stage where she may need it, so what is the impact if she continues on just with exercise? We can't hear you.
Sorry, can you hear me now?
Yes.
This requires really to be a very careful answer, because each individual patient has different histories. And the point is that the indication is surgical. It's highly probable that the curve will progress in adulthood, and at one point surgery will be required by the big impairment of the quality of life. Would exercises be able to stop these curves? We don't have data on that, and probably not. We have data on the fact that they can reduce the rate of progression, so they can delay surgery more in adulthood, but we don't know if they will really be able to avoid surgery. And would brace helps? They can help during growth, but not afterward, as much as we know, even if there are preliminary studies that show something could be done. The point is that surgery is not really mandatory. So if you know that probably your curve will progress anyhow and will create at one point quality of life problems, you can decide to wait and see what happens. But the more you wait, the more will be the risk of surgery, because in adulthood you have more risks, and more difficult will be the surgical approach. So it's really a question that should be checked on a case-by-case basis.
Thank you. And now to Dr. Grivas, we have Gloria and several others who have really asked the same type of question, and that is, what is the long-term impact of scoliosis surgery, and what can one expect if a child has surgery in their later years? And as a follow-up question to that, what are your thoughts regarding tethering?
Let's answer the first question. The long-term outcomes of surgical treatment are regularly now reported in our meetings, the spinal meetings, and we have reports highlighting that one of the major complications in the long term is the adjacent level disease, and also sometimes, problems from the instrumentation the doctors used. Adjacent level disease means that the level of the spine, when the instrumentation ends, is getting degenerated. And this is a major problem because it's we could say it is an iatrogenic problem. However, there are now a lot of reports trying to sort out this problem. And on the other question, can you repeat the question? No, the second question. I can't hear you. You are muted.
Yes. I'm sorry. The second question was your thoughts regarding tethering.
Well, yes. Tethering actually is not a new way of treating. It's a new module in our surgical armamentarium. The first publications on this surgical strategy was reported in Journal of Bone Joint Surgery in 1950s, and initially as an experimental study in pigs, and later on using staples in people who was treated for scoliosis. Now this idea revived, and they are using now screws anteriorly, going anteriorly in the anterior part of the spine, screws in the vertebral body, and tethers. But we have to wait to see the long-term effects of this operation. One of the complications reported recently in one of the Scoliosis Research Society meetings was the breakage of the tether. But even though there was a small number of this sort of cases, clinically it was very important. But another another point we have to highlight is that it is very complicated to indicate the proper patient to do this, because it is difficult to know if the curve will progress, if the curve is mild, it's not, very, let's say 50 degrees. If we have a child with a growth potential and a curve of, let's say, 25 or 30 degrees, then this child may progress or not. It is the first difficulty, and the other is that sometimes, if there is a lot of growth potential, we have overcorrection. So we have to wait and see how time-honored is this method. This is my opinion.
Thank you very much. Now there's a general question for Dr. Donzelli in terms of, is there anything new thoughts regarding the root cause of scoliosis?
Yes, the most important form of scoliosis, which is the most easy to find, is the idiopathic forms, which means that we don't know the real cause. We can estimate that multiple factors are involved in development and progression of scoliosis, and the role of experts is to estimate these risk factors to understand which are the true risks of our patients. But then for what concerns single causes, we have very few answers in this field.
Thank you. There are more questions regarding bracing, and Dr. Negrini, Enarita, and others had asked, and Tara, what can we expect from a brace? Could it actually decrease the curve?
Yes, if it is a very good quality brace, you can decrease the curve, and if it is a very good quality treatment. The problem is with brace is that if you apply an homeopathic dosage of brace, that means you don't use enough hours for what is the importance of the curve, you will not have results. So it depends on the quality of the brace, on the hours of brace wearing, and the compliance of the patient, the acceptance of treatment by the patient. So if you are prescribed 23 hours per day and you use only 18, you will probably not have this kind of results. It depends also on the exercises that are add something to the brace, and it has been proven by many studies that you can achieve improvements.
And now, Dr. Kodvicki, there was a question that had come in from Jennifer asking, you know, the different types of surgeries, but what about the different types of rods and cages, et cetera? The instrumentation that's available. Could you elaborate on some of those?
Yes. This instrumentation is composed of some specific parts. There are two rods that are put along the spine, and these rods are fixed to the spine, or the spine is fixed to the rods, with some kind of anchors like screws or hooks or wires or others. So there are continuous development of these devices, and now I think that we are provided with a very good high quality of these implants. They can be made with titanium, or in the past with stainless steel, but nowadays mainly titanium or cobalt chrome, and they are biocompatible. They can be well put into the human body, so there is no facial problems with these implants. They can stay for life, and it's very rare that we put these implants out. For example, in a very slim persons that these implants can be sometimes palpable, but in a general rule, these implants are left in the body, and there is no special problem related to this.
Thank you. And Dr. Negrini, there are several questions regarding the issue of scoliosis-specific exercises, and you had mentioned in your presentation that there were several, and they wanted to ask if you could elaborate on those. And a follow-up question with that, is there any indication, again, if you could just give a little bit more thought about when it may be harmful actually for the child to have the exercise?
We have two groups of exercises that have shown the best effectiveness through randomized controlled trials that are the best quality studies. They are the CS exercises that have shown effectiveness at the end of growth, and the short exercises that have shown effectiveness in a short period of time. That means at 1 year of treatment. Then there are other schools like FITH, Dobomed, and Lyon School that have shown the effectiveness with lower quality of studies. That means they have effectiveness, but not proven as well as the other schools. So these are the schools actually known internationally. What about the progression? We have seen a lot of cases of progression of exercises, of scoliosis with bad quality exercises. And this is probably one of the reasons why many surgeons say that exercises are not useful or even harmful. Because if you apply a bad type of exercise, you can really make the scoliosis progress. Which is the bad type of exercises? Generally speaking, but this is very technical, is something that increases the mobility of the spine without allowing a good stability. We need to increase the stability more than the mobility. And this is very technical. It's very difficult to explain. You need an expert physiotherapist who's following the expert schools recognized internationally.
In following up with that, we had several questions for Dr. Donzelli, and this will have to be our last question. But all of the questions can be answered and followed up with, and the presenters will be glad to take their particular questions and respond to you via email. But Dr. Donzelli, the question became, you had mentioned in your presentation about them needing to go see an expert. So they wanted to know what type of expert should they go see?
So the meaning of expert is related to the number of patients evaluated by the specialist you are asking an opinion. So expertise is strongly related to the number of scoliosis patients evaluated and being treated every day. Because, you know, it seems that scoliosis is a pathology for most of the people, but in reality it's quite a rare disease. And so to be able to manage and to be able to differentiate between postural problem and the true deformity, we need real expertise. So the number of patients evaluated and treated is the rule we need to define it.
Thank you very much. And I would add that, as you can see today, the experts who are members of the Scoliosis Research Society and the Society on Scoliosis Orthopedic and Rehabilitation Treatment are a good place to begin with to see, because we know that those members are with their peers and they're going through required education and certification, etc. So it doesn't mean they're necessarily the best doctor, but it does mean that they're very serious about their commitment to this condition and to you as a patient. With that, I think we have to close. Our hour is up. Thank you very much for participating.